Hair restoration is one of my favorite topics and an area that is ever evolving. And so I am thrilled to welcome Dr. Sam Lamb, who is renowned for his innovative techniques and deep expertise in hair transplants. Dr. Lamb has authored major textbooks in the field, making significant contributions to the science and the art of how we do hair transplants across the country. His work has helped to constantly redefine approaches in both surgical and non-invasive hair treatment, helping us all to deliver better outcomes for our patients. Dr. Lamb, welcome to Derm Club. It's a pleasure to have you.
Thank you, Hannah.
So
I'm glad to be here.
Thank you. So I want to start by really getting your thoughts on some of the non-surgical approaches taken in hair restoration. With
Sure.
new patients, how important is it to do genetic testing to tailor treatments?
I think it depends. So that there are two routes to deliver medical therapy: oral and topical. I think that for example, if we just use men, which is the bulk of what how I treat patients, genetic testing, if they're doing topical therapy, I think becomes more important because the route is less discernible in terms of the efficacy. A great example is, I always say, about 30 to 50% of the male population has a reduced level of what's called sulfotransferase, the enzyme that's necessary to convert minoxidil into its active metabolite, minoxidil sulfate. And if you take an oral version of that, it bypasses the need for a conversion into that active metabolite, because there is the issue is that the sulfotransferase is not being in the scalp. So when we go topical, a genomic evaluation is, to me, important or helpful because of that reason. And also there's other ancillary therapies such as tretinoin, fluocinolone. Are those necessary? Do they impact the result? Obviously that doesn't come into play when you're dealing with an oral dosage. That being said, I'm actually always surprised when I see results back from the test. I see that dosages that we would think don't exist. I mean, they don't exist, like 0.2 milligrams dutasteride or 1.2 milligrams finasteride or 2.65 milligrams of minoxidil. I think there's a level of accuracy that's there. Can I tell with certainty that exactly
Ross, it
that
froze.
dose has an impact and translates into a discernible efficacy?
Dr.
I
Lamb,
can't
I
say
gotta
100%.
stop you.
Yeah, go ahead.
You actually froze, like completely froze. I don't
Oh,
know
no.
if you froze on your end, but you
I did
froze
not.
on my end for about like a minute.
Oh,
Let me just check my Wi-Fi.
mine,
might have to
I'm
start
on.
over.
Oh,
Is
that
this fine?
sucks. Okay.
5G?
Yeah, don't worry.
I'm sorry. I'm gonna have to. You froze for a minute. I was trying to stop you, but you probably didn't hear me.
Yeah.
So I'm gonna start
No, it's
over,
okay.
but we'll do it exactly the same way.
Okay. So did I just answer the question, or do you want to ask me the question again?
I'm gonna introduce you and then ask you the question again.
Okay,
I'm
sounds good.
sorry
That's
about
fine.
that.
No worries. No, it's all good.
Hair restoration is one of my favorite topics and an area that is ever evolving. So I'm thrilled to welcome Dr. Sam Lamb, who is renowned for his innovative techniques and deep expertise in hair transplants. Dr. Lamb has authored major textbooks in the field, making significant contributions to the science and the art of how we do hair transplants across the country. His work has helped to constantly redefine approaches in both surgical and non-invasive hair transplants and hair treatments, helping us to deliver better outcomes for all our patients. So, Dr. Lamb, welcome to the Derm Club. It's a pleasure to have you.
Thank you.
I want to start by really getting your thoughts on some of the non-surgical approaches taken in hair restoration. With new patients, how important is it to do genetic testing to tailor their treatments?
So I think we have to divide it into men and women. And for women, I oftentimes actually don't use a lot of biochemical therapies such as finasteride, minoxidil, spironolactone. So I find that natural therapies, which I'd be happy to go into in a moment if you like, are actually more effective and don't have the issues of risk. Whereas men, I think biochemical blockade is essential for the majority of men. And then when we look at the biochemical blockade for men, we have to divide it into oral versus topical. When we're dealing with topical therapies, I think the genomic evaluation can be particularly important because the bioavailability of topical therapies is compromised sometimes if the dosing is not correct or the distribution or the components are not there. For example, about 30 to 50% of men have a reduced level of sulfotransferase, an enzyme that is necessary to convert minoxidil into its active metabolite, minoxidil sulfate. And that really only has relevance when it's in the scalp. In the oral form, it bypasses that whole issue, so it's not as critical. So there's other elements such as tretinoin, fluocinolone, and other those things that it's helpful to know whether there's a genetic need for those other ancillary medicines that obviously have no bearing if it's oral. That being said, I have found that genomic evaluation is quite interesting and helpful even at the oral distribution because I found these unusual dosing numbers that just don't exist in standard numbers. For example, 0.2 milligrams dutasteride or 1.2 milligrams finasteride or 3.2 milligrams oral minoxidil. So I still think it's helpful. I don't have an ability to tell you exactly that there's a translatable, if they take a certain dose that I've seen an increased efficacy, but I do feel confident that that tailoring is important, especially as I mentioned for topical and especially for men.
Okay, and I would also imagine that as more future therapies come out for hair, which I'm sure there will be, it will be even more beneficial and impactful because we'll know, oh, this patient doesn't actually have to be on this hormonal therapy, but they could be on this non-hormonal pill instead. So I would be curious to see how that evolves in the future. I am also interested in knowing your perspective on low-level light therapy. It gets a lot of mixed feelings. Some physicians, are confident that it really does make a difference, and some others say they don't see a difference. So, Dr. Lamb, with low-level light therapy gaining traction, could you share your insights on its efficacy in hair restoration? And are there particular cases where you find it more beneficial? Just from my own practice, what I've heard is people see a bigger difference in women, and that might be because they're more compliant with the treatment.
So, unfortunately, hair restoration is a business, and so we're in the business of making money and selling everything that moves. I'm in the business really of making sure that I offer my patients the greatest efficacy and not try to sell them stuff. I don't believe lasers are my first, second, or third line. I've not found the efficacy to be strong enough to justify the expense of the lasers. I do carry lasers. I do use them, but I probably sell a few each year rather than a bucket, so I probably could be a lot more profitable in the way that I sell my stuff. But I just don't feel it's ethical, and I don't feel it is contributory, at least in 2023. I used to sell more of them when we didn't have as many good technologies out there. Where do I see it beneficial? So generally speaking, the problem with laser therapy is if you're using the comb, is that you need to constantly do it, and that can be very exhausting, and I don't think that most people can tolerate from a compliance level. The laser cap has sort of a more global distribution, but it has to penetrate through hair to get to the scalp. If you've got enough hair, especially if there's a lot of melanin, it may be hard for it to penetrate down to where it needs to go. And then if you take a lot of melanin in the scalp, such as African American individuals, it also further makes, mainly in women, I use it mainly in controlling a lot of shedding if there is a lot of and it's more toward the Ludwig III pattern where there's enough exposure of the scalp that there can be efficacy. When there's a ton of hair, I don't think the penetration is sufficient to make it justifiable. And there's just so many better technologies today that are out there.
So it sounds like someone like me wouldn't be a candidate.
If you came to my office and you were saying I'm thinning or shedding, I've got a host of things that I would give you, and laser wouldn't even be on my list.
Okay. And there's something called the Alma TED laser system. How do you perceive its role in the future landscape of non-surgical hair restoration? And are there specific patients that you would think would benefit from this technology?
Funny thing is, I just heard about it yesterday. I missed the India ISHRS. I heard Gorana Epstein give a brief talk about it. I don't have any. I don't have any clinical experience with it. I don't have that much knowledge about it except for what I heard. I think what I am just blown away with are the natural therapies, especially for women, but also for men, that I used to poo-poo and thought were of moderate and minimal gain, and now I find them to be incredibly potent. So I would say that even though I don't know anything about this technology, I mean, besides what I heard, and I have no clinical experience whatsoever, nowadays I have a 360, a 180, excuse me, thinking about how I see things, and I would say that probably does work quite well.
So, I know at your office you do something called hair stem therapy, and I would love for you to share with us what that is. I understand that it's a non-invasive treatment for hair loss. How do you compare this to, say, PRP? And do you think one is superior over the other? And who is an ideal candidate for a hair stem therapy?
So I think I present hair stem as sort of PRP 2.0. I no longer really perform PRP. I always say there are three major problems with PRP. One is it doesn't work that well. Two is it hurts like heck. And three is that it can cause major hair shedding, especially in women. And anything that is painful. So there are two things that minimize compliance: pain and cumbersomeness. And PRP suffers from pain. So this is basically bioidentical plants that are at a high concentration of growth factors infused through the scalp. And shockingly, my success rate is over 90% with this. And the results of the growth are incredibly fast. I mean, I see them within 2 to 3 rounds, spaced out once a month for 3 months, and then I maintain it twice a year. I use it in my practice mainly for women, because, as I said, I don't really often offer women minoxidil or spironolactone because I just don't find they need it, and I find that there's more problems in women with those medications than there are benefits. So I'm 100% natural on women, and I only use minoxidil or spironolactone when there is a absolute, I can't get it under control with everything else I have. And hair stem is one of my first line defenses for women. And I find it to be quite effective and rapid in its growth without that phase of shedding that you see with biochemical therapies like minoxidil, finasteride, or spironolactone.
So is it a laser machine, or what kind of device is it?
A machine that actually pushes the growth factors through the scalp.
And are they going to the dermal layer, or they're going deeper?
It's penetrating through the dermis, yeah.
Okay. So let's go and talk a little bit more about hair restoration and hair transplants. In terms of doing an FUT, which is also known as the strip, line closure techniques, when closing this line or strip, do you prefer sutures or staples to close it? Some physicians I've seen do staples. They say it's much easier and it heals similarly. I was actually surprised when I first saw it being done because I thought using sutures you may get a little less of a scar. So just curious to know what you do in your practice.
So I use sutures over staples. I don't think staples are bad. I think staples are actually allow pretty darn good healing as far as what I've seen. I don't use staples because they're painful. And sutures really have very minimal discomfort, and I've talked about in my books, especially the latest ones, how I've been able to use botulinum toxin therapy injected in to just wipe out any minimal discomfort afterwards, almost immediately, like nanosecond correction. But what I found is that staples are more uncomfortable. And so I feel that I like sutures still, and it's not difficult to do for me, although you're right, staples are easier,
Okay, and then how could you explain, I know you mentioned the Botox, would you explain to us how your thought process behind how this Botox is helping in scar management?
Yeah, so it's not really helping in scar management. I believe Botox is incredibly amazing for scars. I use it for mole excisions and any kind of, like I don't do it for facelifts, rhinoplasties, or hair transplants because if you do those techniques in discrete zones, they heal so well that Botox is superfluous in my opinion. However, I do use Botox for exposed scars. So I use Botox really for pain management postoperatively if they have any. About 10% of my patients after a strip procedure, FUT, have some achiness or discomfort, especially if they're lying on it or lying to one side. And I can get that down to pretty close to zero in a second.
Okay, so then since you're not using Botox for scarring, is there anything you do use for scarring? Say, I know, I'm sure with your suture technique, you get minimal scars, but say a patient comes back 6 months to a year later and their scar is not as lovely as you had wished. At that point, what do you typically do for the scar?
So, when we say, fortunately, the vast majority do heal very well and seamlessly. Of course, I don't always get 0 millimeters. I may get 2 or 3 millimeters, and I counsel the patients on that. And if there's a little bit of widening of the scar and they're not bothered by it, I leave it. Oftentimes, that just continues to fade and not become as prominent. But if you're talking about if the scar is a little thicker, then I will use Botox, botulinum toxin injections into the area. I find that Botox treatments are actually the safest therapy out there compared to almost any other technology such as triamcinolone or steroids or 5-fluorouracil. But I do also will use 5-fluorouracil. In the very rare case there's thickness. There really should not be. But that's what I do. Now, I just thought of something. I had a African-American lady, and I don't do FUE on women for the most part. And this woman had a history of keloids that weren't remarkable, but she had some body keloids that were from tummy tucks. And I still felt convinced that I was able to do her strip procedure safely. And so in her situation, at the end of the procedure, which I don't do for normal people, I used a 50-50 mix of 5-fluorouracil and triamcinolone 40 milligrams per cc, total maybe about 10 cc's, and injected it very carefully into the wound. And I repeated it every 3 to 4 weeks, and she never developed, not only she did not develop a keloid, she didn't develop even a barely perceptible scar. But I think that's overkill for the vast majority and may also cause some atrophy.
Interesting. So,
but to answer your question, if they came back with a scar that's less than perfect at a year, in other words, it's wider and it's not ideal, then the answer to, is that the question you're asking?
Yeah.
So then that case, if they're going to do another transplant, then I could take out the old scar. If they're not going to do another transplant, what I find is that just removing a scar and closing it generally doesn't lead to a much better scar anyway, so it's not the easy way to fix it. It sounds intuitive that, as surgeons we think scar revision is cutting out and closing it, but it doesn't necessarily lead to perfectly better scars. Even if you think, well, that surgeon did a bad job and I'm going to do a better job, it's just the nature of the healing. So what I find to camouflage scars better are going to be SMP, scalp micropigmentation tattoo into it, or harvesting hairs either through FUE. Sometimes what I do is I use beard, because that, if it's a guy obviously, because that way, and usually the guys are bothered because women have long hair usually, and that way that way I don't have to have another scar, I don't have to steal scalp hair again, and they don't have to shave anything for FUE. So my go-to usually is beard hair FUE to transplant into a widened scar, but my first easiest was just SMP.
Okay, and then say they're coming in for their second transplant. Do you do a different type of closure?
That's a good question. What I would really look for is tension on the wound. Maybe I took too much tension on it. And it's interesting, my new book that just came out a few months ago, I go through a very detailed algorithm of how I manage scars how I manage second harvest, tertiary harvest. Do I take out the old scar? Do I partly take out the old scar? Do I crisscross over a certain area? And that's a very difficult algorithm, but I will try to be as brief as I can with it, is that if there is a very wide scar, the concern is that the person doesn't heal well, but if I take out the old scar, there are no grafts usable, because even a thin scar can deplete 20-30% of what you would have otherwise for usable grafts. And if I harvest some, I could harvest somewhere else. So if I'm thinking, okay, the scar is here, and it's bad, I could harvest, for example, if they're not too young and I'm worried about recession, I could harvest more temporally where there's more virginal area, and then I could take some beard hair, transplant into it, or whatever it may be. But if it's just slightly wide, okay, it may be, maybe just some technical error, or maybe it's just they didn't heal as well. I would do what I've noticed over my last 10 years. One thing that's helped a lot, besides continue to add more and more tumescence, is to allow about 3 weeks of suture time rather than my old time, which was 14, 15 days. I found that if you can hold for 3 weeks better, so in that person that may have not healed as well, I may hold it for 4 weeks to really let the epidermis, dermis seal down well.
Oh, interesting. Okay, because typically, I know the scalp heals pretty quickly because it's well perfused, but obviously 3 to 4 weeks sounds like a longer time than you would leave for, say, a mole in your arm. But it sounds like you're getting better results with this prolonged period of time.
Well, interestingly enough, I leave mole sutures in for 4 to 6 weeks now, and I don't see the stretch marks, but I'm using tiny little Vicryl sutures. But it's interesting because I always tell facial plastic people or plastic people or body or derms that are doing work on the face not to think about the scalp as the same way, because I found that dissolvable sutures in the scalp don't heal well. They cause too much reaction in the hair, and they can cause scarring and hair loss. So I use monofilaments like a 3-0 polypropylene or nylon. Whereas in the face, except for the upper eyelids, I actually use a 7-0 Vicryl suture that sits in there for 4 to 6 weeks, and I find that it reduces the risk of separation. Of course, I do multi-layer closure in those, but it actually, because what happens in the skin is that the dermis, even though the dermis is held well with the like a monoderm, whatever it may be, the outer portion may separate just by a millimeter and cause a stretch scar. In the hair, I find that multi-layer closures in my hands, although a lot of people love that, I find that in my hands causes a foreign body reaction and can jeopardize hair follicles subcutaneously. So very different ideas, but the mole I actually leave in dissolvable epidermal sutures for longer.
That might be something I have to try. So, in terms of FUE versus FUT, I'm wondering if you have noticed any trends, even perhaps regionally, where men prefer to wear shorter hairstyles, so therefore they're going to say, okay, I'd rather do the FUE because I don't want to have a linear scar, even though your scars sound to be very minimal. Have you noticed any trends in terms of a preference for one procedure technique over the other?
Yeah, so the vast majority of my patients, I would say, prefer FUE. Just because of the online marketing, and nowadays there are a lot of doctors that can't afford to have a full-time staff with them, so they just do FUE, so they make the other one sound like a dinosaur, and it's inappropriate for everyone that moves. But then I've also seen a trend of patients that I've done a strip on, tell another person, hey, try to find my scar, look at it, and they go, oh my God, that sounds good, I'll do that one, I'll just shave my head, especially if they come with long hair or if they're a female. 30% of my transplants are women. So it really, so I found those two trends in general. If they're sort of hair transplant naive and they've never been my patient, they come in, they probably want FUE. But as I said, I just don't do it for women, and I do it in select men. Not always. It just has to depend on a lot of factors.
Okay, and are you doing a manual FUE?
I'm doing I use Trivellini and WOW devices, more the WOW device by Jean Devois, Really today, I wrote my first book on FUE. I was edited that book in 2016. It was the only major book in the world on this, and it still is. And by 2017, my book was completely outdated. And so my new book that came out last year is, oh my God, it's 60 chapters. It's 2-volume set versus the one that was only, I think, 20 chapters or 16 chapters. I can't remember anymore, from 2016. And that new book, FUE book, the reason why I had to write it was simply because by 1 year later, with the advent of what's called hybrid technology, what I wrote was completely outdated. You know what I'm talking about with the Dubois and all that.
It's just incredible. Like, as soon as you're done writing one book, the technology is outdated and you have to update it. It's pretty funny.
Yes.
So what are the key features of the WA? It sounds like you're using the WA pretty often.
So I assume your audience is not doing a lot of hair, so I'll sort of do a very baby down understanding of it. So if you think about older technology, before 2017, it was divided into two major camps. You had the blunt guys and you had the sharp guys. The blunt guys said, look, there's too much transection with sharp punches, so don't use it. And then the blunt guys said, no, the sharp guys said, hey, the blunt ones just buried grafts. The grafts look mangled and chewed up. We need to do sharp. So there was these two camps. And in 2017, Trivellini and Dubois independently found a really amazing solution that is called hybrid technology, which basically it's both sharp and dull. The way it looks like it, they call it a trumpet, where it's a flared front end where the graft is facing the blunt side. So there's no sharpness to the graft, so it's much easier to harvest, much less transection. The grafts look amazingly good, but the edge is sharp, so that with the sharp edge, you get a clean dissection without a high risk of transection. And the second major component of these new hybrid technologies is oscillation. So prior to 2017, almost all of the blunt and sharp, actually all of them, were using high rotary devices that went in like this. Now they just go in like this with oscillation. So the benefit of that is that you don't get the high torque and you don't get this torsional injury. So the grafts look amazing. And the risk of transection is much lower, and the learning curve is much easier for the beginner compared to what it was before.
And are those considered hybrid punches?
Yes, correct. Yeah, the hybrid term is a term that I forgot who came up with it, but it's just a colloquial term to describe that. Yeah.
Okay. So I'm curious to know, I think I've listened to one of your videos where you told us that you had the ARTAS robot in your practice, but it's kind of getting pretty dusty and you're not using it as often. So why is that? And it sounds to me like you're doing manual FUE pretty frequently. So has your manual FUE tools and techniques kind of completely replaced the ARTAS robot in your practice?
The short answer is yes. My ARTAS was collecting dust in the corner. Now I've officially moved it out of my room. I can't even give it away. And so the problem with that technology is you have to understand how ARTAS works. So ARTAS it sounds sexy. It's a robotic. Yes, it's on my website. I hate to say it for marketing purposes because people are like, oh, they like robotic. But I don't use it anymore. So what the problem with the ARTAS is that it is a device that Jim Harris came up with, and Jim is really the pioneer of blunt technology. He's the one that pioneered it, and I love Jim. He's a great guy, but that he developed it, so he's using technology from 2010 that really hasn't updated it. So essentially what that technology is, and I bought mine in 2011, stopped using it about 8 years ago. So what that technology is that it's a sharp score and then a blunt tip that goes down into that onto the graft itself. So it sounds like it's combining both sharp and dull, but it's doing it in a really not a good way. The grafts look terrible. You can't really access low points around the scalp, the top points. It only does the middle side. The robot really doesn't have the insight that the human mind does. My ability to see the graphs, it far exceeds what a robot can do. So I really haven't used it in many, many years now.
So is the manual FUE approach, do you think it's more tedious and time consuming?
There's no doubt. And just for semantic purity, usually when we use the word manual, we think about one that is not powered. So I'm using powered FUE, but it is definitely manual in the sense that I'm doing it by hand. So it
Right.
is manual, but it is exhausting, cumbersome. But unfortunately, based on 2023, the only way to do it is to harvest it by hand. And I do all my own harvest myself. I don't delegate this, which is another whole story. Which I would just briefly say, the trend is terrible now that doctors are not even involved anymore with the procedure. They don't even understand hair diseases. They don't even understand how to harvest. They don't even know what they're doing. They hire some techs to fly in. And I just saw a guy that went to Turkey last week, a physician in his mid-30s. He had done 2 consults with me, and they harvested from the nape of the neck all the way to the top. They completely wiped out his donor area. His whole backside is scarred. And what's going to happen in 5 to 10 years, if the grafts are even fortunate to survive, is that they've harvested into the crown, the mid. It's like crazy. These are not even donor sites. And those areas are going to be lost. There's going to be scar tissue. I mean, I can go on for the whole hour and talk about this because it's so devastatingly horrible what's happening to the industry today.
Yeah, I actually just met someone last weekend who told me he went to France and had 5,500 grafts, which I thought was a lot, and I already could see that mothball, like moth-eaten appearance on on the sides of his scalp. So yeah, I think it's kind of like this trend that's going on because people are trying to find it at a reduced cost, but it's ending up with very over harvesting and complications. In terms of using the FUE, you know, obviously there's very few procedures out there that are completely scarless. Do you get any hypopigmented scars? I know with the artists, it's kind of, they used to market it that it was like this scarless procedure, but
That's
then
called
it
lying.
kind of came out that that there was hypopigmentation around the areas that were being where the extraction was going on. So, do you find that using these power devices when you're doing the FUE procedure, do you get any of those hypopigmented scars?
Absolutely. The scarring, everything is scarred. You get scarring no matter what you use. Jim Harris, again, did an interesting study where he looked at the punch size, like a 0.8 versus a 1.0, and found that there's actually no difference in what the size of the punch does in terms of engendering hypopigmentation. So we can't use a certain perfect punch that avoids scarring, and this is why it's so important with their head. And I mentioned to every single person that's during a consultation, this is not a scarless procedure. The one exception to this rule is the beard. It is very interesting how the beard is relatively resistant to scarring and hypopigmentation. I feel pretty darn confident to harvest hairs from the beard and even a Central African individual and have very little risk of hypopigmentation. Now, theoretically, it's always possible. I do consent them for that. But I feel a very low threshold of fear I have a high threshold of fear, I should say, in terms of worrying about hypopigmentation in the beard. Now, have I seen hypopigmentation in the beard? Yes, and actually in a white person, I remember, but I had done like 8 rounds on him to try to actually rebuild his entire scalp, and you really couldn't see it, and he had such older skin that was not that visible. But that's the only area that I would say is relatively immune from scarring. Not the chest, not the scalp, but the beard.
Which is actually very ideal because everyone kind of sees your face before they see your scalp. So that's kind of works out well.
Correct.
And then in terms of your flow, you know, every surgeon has a different way of doing things. Do you typically anesthetize the front and make the recipient sites first and then go and do the FUE portion and then come back and obviously numb the back and then come back and put them in? Or do you do it where you're first or doing the FUE section of the scalp and the donors, and then you come back and do the recipient at the end?
So my order for FUE versus strip are inverted. When I do a strip, I do the strip first, and then I'd have a calculated number of grafts from the strip based on a 2 centimeter segment in the occipital region and the lateral portion. That will give me a calculated projected number, and then I make my recipient sites after I've already closed the incision. With FUE, because graft, it's very labor intensive to harvest. In addition, you don't want to burn out and create a moth-eaten appearance. You want to have the minimal number of grafts to get the maximal number of impact for the patient. You don't want to just high graft count, steal everything you can. I do the recipient sites first, followed by the harvesting, so I know how much to harvest. That's a broad picture. In terms of anesthesia, so I'm sort of unique. I have a Joint Commission accredited facility, so I knock patients out with intravenous sedation or pain management. I don't go quite as deep when I'm dealing with FUE, because they're going to be in a prone position versus a strip where they're going to be in a supine position. But the way that I do the quick summary of sort of the anesthetic sequence is after I knock them out, first thing I do is I do a couple spots along the mastoid and low down to the occipital region, where I'm just hitting the nerve with just a few drops of lidocaine, rub it into the nerve. I go to the front, I do a supraorbital block, I do a auriculotemporal block, which is right here, and then if I'm doing a temporal point in a male or female, I'll do a zygomatic-temporal block, let that sit for a few minutes, and then on the back side, I find that the way to anesthetize FUE versus a strip is that with a strip, I've got to do a ring block. With FUE, you really want dilute anesthesia, and there's several reasons why. Besides it hurting less, dilute anesthesia, shockingly, will actually last longer, so it lasts the whole day, and it has very low toxicity, because if you think about FUE, you're harvesting a wide zone. You use concentrated anesthesia over a wide zone, you have a high risk of toxicity, and shockingly, high concentrated dosing does not last. The dilute lasts. And I find that ring blocks don't work that well for FUE, and they don't provide enough anesthesia in terms of the, hemostasis. So I use a dilute lidocaine-marcaine combination. It's documented in my new book. I just promote that. I don't make any money on my book, so I go to charity, Hair Transplant 101. You can find it on QMP.com, QualityMedicalPublishing.com, QMP.com, along with the new lecture series that is also on there that I did. But the dilute anesthetic of lidocaine and marcaine placed in there does great. So then I'll put that in there. I will then and I'll anesthetize the front. What I try to do is get the recipient site anesthetized as early as possible. I find that when you get at least that tumescence in there, site creation, but more importantly, the graft placement has much less bleeding if you can get that dilute tumescence in the front. The dilute tumescence in the front does have a very low triamcinolone content, so that there's less swelling in the face. Dr. Abbasi figured that out. I will then harvest a couple sites to make sure the grafts in different zones, because the grafts are different lengths. That will allow me to adjust the recipient sites lengths to what I need. And then I test those sites to make sure that they fit. And then I make my recipient sites. And then before I go and harvest, I'll add a bupivacaine. Sorry, I forgot to say this. I do a ring block to the front. So I will do a lidocaine ring block after I put the nerve blocks in, and then I will reinforce that after recipient sites with a bupivacaine ring block and nerve block, and then I'll harvest, and then my staff will place. Hopefully that wasn't too fast. I'm sorry, I know that was a lot of information.
And what are you using to make the recipient sites?
So I used to use bent needles. I only use bent needles for eyebrow transplants because I need them. It's hard to describe this, but I need to go flat enough with it. I use solid core needles, and the reason I use solid core needles over blades is several reasons. One is I like sagittal parallel sites because I think there's a lot of reasons, but I can see the flow. My staff can see the flow much better than lateral slit sites. I don't think lateral slit sites are really, or perpendicular sites are that beneficial. Solid core needles have a lot of benefit over bent needles. One is because they're not bent, and I can create a stop check on the handle, and it because there's no hole in it. There's no epidermal entrapment as you make the sites, and I find that in that very low likelihood that I get some cysts, I've been able to really reduce my number of temporary epidermal cysts postoperatively by using solid core needles. They also don't dull as much, and because there's no bend in it, the force of the delivery is more standardized as well. So for all those reasons, I like solid core needles. I don't like cut-to-fit blades. I think I'm a pretty gentle surgeon, but I find that when I was using those blades, they bent, they dulled very quickly. I couldn't, and they slid. So in my hands, now a lot of my great colleagues use cut-to-fit blades. They use different blades, and they love it, and it's great. I have no problem with someone else using it, but you asked me what I use. With a sharp point coming down as a solid core needle, when the needle engages, I know that site stays there, and then I enter. With a blade, the problem with a blade, no matter how you slice it, especially if you go sagittal though, is that it slices, and sometimes when you have a blade, it can slice a hole that's too big and is less predictable in my hands. Again, my hands, not someone else's hands. So especially for beginners, but especially for me, I've been doing this for 21 years, I still like needles.
So you have more control. And are you using the same size
No.
throughout? Or you're changing the size?
I use 19 and 20 gauge needles for 1 hair grafts, and I use 18 gauge needles for 2 and 3 hair grafts for the most part. Unless I'm doing eyebrows, then I'm using bent needles because the bent needles can go flatter. The problem with the hub on the solid core is I can't go all the way flat down to about 0 degrees. So when I'm doing like temples and I'm doing eyebrows, I'll actually bend needles. And I'll be using for eyebrows closer to 21. African Americans, I may be using 20, rarely 19 gauge, but I'm usually using 21, 22 for eyebrows.
Okay. So before we wrap up, I want to talk a little bit about post-op care. What's your approach to post-op care and hair restoration surgeries, and how do you ensure that you have a high patient satisfaction and optimal results in the healing process? And another thought I had was, have you come across anything in practice that has minimized the amount of shock loss someone may get after surgery?
Okay. So to answer your first part, aftercare for me, I don't use bandages, I don't use copper peptides, I don't use things like that. The only thing that I like, number one, is ATP spray with I think that the liposomal ATP can help with graft growth. I've been using it since 2014, so almost 10 years. They just spray it every hour while they're awake until it's drained. I also use that ATP as a storage medium for my treatments. I also spray the graft and the sites and during the course of the surgery for both FUE and strip. And that's about it. The only other thing that I do like is Surgery Pro Heal, which is basically, or Surgery Heal Pro. I always get backwards. It's a one of the brands that can be used for a hypochlorous acid. Hypochlorous acid is not an acid, but it's an amazing treatment. I use it if my dog gets an infection, my kid gets a wound or something. If I've got an issue, it kills all bacteria, fungi, and viruses really effectively. And so I don't always use it prophylactically afterwards, but I do it perioperatively during the procedure. Like, for example, if a strip in the wound, I'll spray before I close it, and it's a great added benefit. I don't think they need antibiotics. I don't think they need other things. Now, of course, if they have MRSA, things like that, then we're looking at prophylactic antibiotics. Second part of your question. Do you have a question about that first part?
Yeah, I just wanted to ask you, we can go back, but so you mentioned the liposomal ATP. Do you also use that as a holding solution for the grafts?
Yes, I do. Absolutely. So when I'm doing a FUE, the grafts, when I harvest them out, they go, when I'm harvesting out, they go straight into PRP, and then they get over to my staffing table where they're sorting it and then placing it into the ATP holding solution. The reason I do that is based on some studies that Indian guy did. I can't remember the name. I'm sorry, I don't remember. But there's a physiologic bath that by exiting out to a room temperature PRP, I think there's less inherent shock when the grafts come out. When I do strip, it's the same thing. When it comes out, it actually goes to PPP because I inject the PRP, but it comes out to play the pore plasma at the strip, and then as the grafts, ATP hypothermosol bath.
Do you think spraying it after surgery is enough to be able to like penetrate and really make a difference? Because some people feel like, you know, it really has to like be in the hair follicle to make a difference, and just spraying it is kind of like watering plants in a way.
It's a great question. I've been using ATP hypothermosol, as I said, for close to 10 years, and I've never segregated the two components from the spray versus the intraoperative usage. So you're right, maybe all you need is the holding solution. But I definitely saw an uptick in terms of the grafts being actually finer, less traumatized in appearance, and in terms of faster growth, more finer. So I definitely am a believer in it. At the same time, it's a great question. I don't know to what extent there is, but I have extra. So it's enough, and my formulation is in my latest books about how I use ATP. It's in the FUE book that came out last year, as well as my new book, the 101 book that came out this year. I detail exactly how I mix and put into different areas. So it's a bonus that I have anyways. I guess the patients feel like they're doing something. I think it's probably helping, but I can't tell you with certainty.
Okay. So going back to the original question, have
Yes.
you noticed any way to reduce the shock loss after surgery?
Yes. So for women, obviously, I reduce the epinephrine load. That's also in the book. Just by having the epinephrine load, that can help. Not going absolutely insane with the tumescent load can help, not dense packing, because women are really the major telogen. I hate to say this is going to sound promotional, and I do have financial interest in it. I developed this product called FolliFlow. It's on Amazon Prime. I have it here. It is a amazing plant-based shampoo, conditioner, and spray that rapidly shuts down the shedding process. I've seen a marked reduction in postoperative shedding. I used to use minoxidil perioperatively for 6 weeks to minimize shedding. I no longer even do that. I just use my FolliFlow for a month leading into it, and then a month leading out of my surgery. My friends in the facial plastic surgery world have bought up and actually wholesale my product because for all brow lifts that are worried about telogen loss and shock loss, they're using it, and they swear by the fact that they can reduce that telogen risk. So my nanny had buckets of hair in throughout all my Roombas, and within 1 week they're all clear. So there's nothing faster, and of course I told you, unfortunately I do have a promotion, I have a financial interest, but it is it's amazing. It doesn't leave your hair sticky, and it really can help a lot. Is it perfect in everyone? No. I have some patients where the shedding just doesn't work, or it still does not perfect in terms of postoperative shedding, but that's my number one thing.
And what are the natural ingredients that are incorporated into the FolliFlow?
There are quite a few, to be honest with you. I don't even remember all of them, to be honest with you, but Redensol, caffeine, biotin, there's a huge list. I worked with a colleague of mine out of Boston to develop this product.
And what do you think the mechanism of using these natural products, how do you think that's able to decrease the shedding?
I don't know, but it absolutely works better than anything I've ever seen. The other thing I'm doing now is something that I'm patenting right now that I can't tell you what I'm doing, so I only mention this. I'm using botulinum toxin, not in the scalp, but I'm doing a trigger release point that is actually rapidly reducing shedding, so that'll be a little tease for you and your audience for the months coming up. But these are things that are really crazy because I'm getting better shedding control with non-biochemical therapies than I am with biochemical therapies. And this is why I'm hugely passionate about this, much more than minoxidil and finasteride for shedding.
Yeah, well, Dr. Lamb, it seems like you always have your finger on the pulse of the latest innovations. What upcoming advancement in hair restoration are you most excited about? It sounds like what you just mentioned might be one of them.
I'm very excited about it. I'm very excited about it. I wish I could tell you more about it, but you just have to stay tuned. It is a game changer that I will be talking about. I really need about a year before I even disclose it, but it will be something that it's a reprogramming of the entire hair loss. I don't know how to describe it, but just the process.
Okay. Dr. Lamb, thank you so much for your time today.
My pleasure. Thank you, Hannah.
It was great having you, and I'm excited to see what comes next.
Thank you so much.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.